Welcome. My name is Michael Mallinson. I am the President of the Canadian Spondylitis Association. On behalf of the following patient groups, the Canadian Arthritis Patient Alliance, the Canadian Skin Patient Alliance, the Canadian Psoriasis Network, and the Canadian Spondylitis Association, I am pleased to introduce Dr. Neil Shear as this evening's speaker for Biologics, Your Treatment, Your Choice. Dr. Shear is the head of dermatology at Sunnybrook and Women's College Health Sciences Centre and is director of the University of Toronto's Drug Safety Research Group. He has published over 200 peer-review papers and is chair of the Canadian Association of Professors in Dermatology and president of the Canadian Dermatology Foundation. Please welcome Dr. Neil Shear.
Welcome. I'm Dr. Neil Shear, and I'm going to be speaking to you about biologics, your treatment, your choice. Before I start, I would like to explain that I have worked with some pharmaceutical companies, and these are listed here. This is something we do now as a standard procedure so that you understand that we have worked with several companies and often are being paid for doing these things. Also, during this presentation, I hope you have a chance to write some questions if you need to have any answered, and to stay at the end to hear other people's questions and the answers to those. So what are biologics? Biologics are actually an important class of drugs, and they've been around for a long time. And when I say drugs, I really mean therapies, things to make us better. Traditionally, we have aspirin, which is one of the oldest chemicals that we've used for treatment, and we're still using it today. This is from the late 1900s. Now, during that time, we found other medications like insulin. Insulin was taken from actual animals and had to be isolated. But over the years, we've learned how to tame small bacteria and other cells to make insulin. When you get insulin today, it's a biologic. It's made by cells, and it's made in a complex process. Since then, we've had even more complicated biologics. These are often called glycosylated biologics because they have sugars added to them. These are very large molecules. The other term that's used for them are monoclonal antibodies. Now, when you're making a drug, a chemical, or a biologic, it's two totally different processes, and we'll be coming back to that over and over again. What is the difference between an aspirin, insulin, or one of the medicines I'll be talking a lot about is called Remicade or infliximab? What are the differences there, and why does it matter? Well, that's really what this whole exercise is about. If we want to make a copy of aspirin, nowadays there are simple ways of getting all of these bits of atoms together to make aspirin. If we want to make a large biologic or monoclonal antibody, like infliximab, it's not so straightforward. In this figure, you can see a cartoon, if you will, of aspirin and infliximab. The aspirin is quite small, simple. Everything you're seeing there are all the atoms that come together to make it. And when you add up the weight the way scientists and chemists do, you'll see that it comes in at a number that's about 180. If we take infliximab, 180 is nothing. It's a rounding error. In fact, it's 144,000 before you even get to the 180. It's huge. It's 1,000 times bigger. We're talking about something that is very complicated. But wait a minute, if it's that big, maybe it's dangerous. But it isn't. This is the kind of protein your body makes all the time. These are like antibodies that protect you from infection. This is what's going on here. These are big and they're complicated. And the amazing thing is, now, over many years, scientists have actually pulled off making these, and they're used to treat many diseases, from inflammation like psoriasis to treating cancers. One of the phrases we often hear in this area is that the process determines the product. What does this mean? Well, when we're making something that's complicated, all the steps you go through can matter, some more than others. Baking is a common example. You can take all the same ingredients, and whether you're making a souffle or something else, it's a process, and that process, if it changes in certain ways, comes out with totally different answers. One of the best explanations I ever had in real life was at a cheese shop, where the person was allowing me to sample cheese. And he gave me 3 different cheeses to taste. One was hard, one was soft, one was sharp tasting. And then he said to me, you know, all of these are made up of exactly the same components, exactly the same amount of milk from the same place, everything. It's just that the process to make them was different. That's what we're talking about when we say that the process determines the product. Here we have some clinical pictures, and on the left are diseases. The first disease at the top is a small picture of psoriasis. If you have psoriasis, you'll know what this is about. But if you don't, it's a scaly condition. It's thick, it's itchy, it's painful, it's always with you. You don't get a day off. It's miserable. People hate it, and people are shunned. On the right of that is the clear skin in the same person. The reason their skin is clear is because they received a biologic medicine. To get a biologic medicine in our current environment, you would have had to be on many other treatments first. You would have been on creams, you would have had light therapy, you would have been on pills. And the reason they received that specific biologic was because those weren't working. And for me, and I've been practicing for a long time now, for me, what I'm seeing today is a miracle. It's things, if anyone had asked me to wish for something other than waving a magic wand and making psoriasis go away, I never would have believed we could treat people so effectively and so safely with the products we have. Underneath that is an example of arthritis, but it's also involving the nail. And when we have arthritis in the joints in the hand, the nail is usually involved. The nail can look as bad as here, where it's got all kinds of yellow discoloration, it's thick, and it's got little holes in it and what we call oil drop stains, and the person has arthritis in the joint. They can't use their hands because of the pain and the stiffness. They say, my hands feel frozen. Also, they can't socialize. When they talk to people, their hands are tucked under their armpits. When they eat, their hands are under the table in public. It's embarrassing, it's humiliating. For many people, this alone is enough to consider a biologic, enough to make them say, look, I need to have my life back. And of course, inflammatory bowel disease on the bottom. Crohn's disease, when you're looking into the bowel and you're looking at these ulcers, all the things that are causing the bleeding, the pain, and the total impact on someone's social life, their sexual identity, their ability to relate to other people, or even plan ahead. These diseases now have been changed dramatically because of drugs like infliximab. The picture is sort of a cartoon of all the bits and pieces that come together to make a large antibody. In this case, it's an antibody that we're giving to people, a biologic, a treatment to help make them better. One of the issues we're facing today is new copies that are coming out. These are copies of the originals. Some of those originals are named here. Now, these copies are not really copies. They're sort of like if you had a photocopier and you took a picture of somebody. It's not the same. It's a bit different. And how different it is matters. And it mattered a lot to the countries that have health organizations like Health Canada, where they had to decide, how do we manage these? What do we do? Well, it wasn't easy for these big types of treatments. It wasn't easy to figure it out, and it wasn't easy to even come up with guidelines that everybody agreed with. But I think the principles are there. First of all, the naming. In Canada, these are called subsequent entry biologics. Biologics that have followed on a previous biologic. However, internationally, we're hearing the term biosimilar more and more. So when I speak about this, I'll probably be calling them a biosimilar. You'll see the short form SEB for subsequent entry biologic. But in fact, we're really always talking about biosimilars. So please forgive me if I keep changing the name. Let's get back to this baking example. No example's perfect, but I think you get the idea. On the left, you have Twinkies. And you can reach into a box of Twinkies if you remember what these are, or anything like that. And if you pull it out, they're all going to be the same. You're going to look at it and know it's exactly the same. When you try and make a cake, it's different. You can't get them exactly the same. There are differences in the taste, the structure, the size. Does that matter for a cake? Maybe not so much. It did at my daughter's wedding when she didn't get the cake that she wanted. But for other people, it might be perfectly fine. It tastes delicious. Well, it does matter for biosimilars. For biosimilars, when you make small changes, it could have a big impact. When we think of similar things, many of you will have been on a medication. and you went to the pharmacy, and you could be asking for something as simple as aspirin, but you got a different kind of ASA. Does it matter? Probably not. Why not? Well, because these are chemicals, and these are easily synthesized to be exactly the same. And then when they're put into a pill, that changes things a little bit. However, there are what are called bioequivalence studies. You give that pill to healthy people, you measure the aspirin in their blood, and you decide, is this the same as the originator product? That's important. That's something that all manufacturers of generic or copy drugs need to do. It's different for SEBs. We can't do that. We can't measure it in the body exactly the same way. And so what happens is there are many tests that are done by the companies that make these and the agencies like Health Canada that evaluate them to make sure that they're as identical as possible, realizing that they really may not be. They may just be similar, which is another way of saying different. So speaking about Health Canada and the guidelines on biosimilars or SEBs, the kinds of decisions that have to go into this are based on evidence. We hear a lot about that. Doctors like to say, when I make a decision, it's based on facts. Now, we know there's an art to medicine, and we have to make decisions based on individual differences in patients. Yet the original process starts with us knowing the facts. We need to know the rules on the highway. We need to know how to drive a car before we can pick any car. What are the variables that are looked at if you are a regulator like at Health Canada? Well, first you would want to know if you have a drug that's been used usefully in many different diseases, what's the evidence for that? Well, for a drug like infliximab, there would have been studies that were done. And those studies would have been in people with psoriasis, psoriatic arthritis, inflammatory bowel disease, ankylosing spondylitis, with the view that you wanted to prove that it was useful, it worked, we know exactly how much to use, and we know how to use it. How often? Every 6 weeks, every 8 weeks, what works, what's safe, and then after that it would be studied for a long period of time, looking for side effects in what we call the real world. For the biosimilar, it's a bit different. For the biosimilar, it may just be a small number of patients in 1 or 2 diseases. That isn't ideal. And not every regulatory agency is happy about that. And I have to say, Health Canada has very strongly said that we would not like to extrapolate or make up a fit if there isn't data to support it. Another issue that comes up with biologics, naming. Naming's very important. I was at a meeting that included many patient groups and physicians who were leaders in the areas of nephrology, oncology, cancer, rheumatology, and other areas, and myself in dermatology. And the question of naming came up. Now, I think naming is a big deal. And I was very surprised, impressed, and gratified that the patient groups put it as one of their top 1 or 2 issues. In other words, if I went to buy aspirin and a pharmacist said, well, here's 3 or 4 different ASAs, or acetylsalicylic acid, I could say, well, I don't know, which one's cheaper? So this one's cheaper, it's fine. Ibuprofen, same thing. I could get Advil, or I could get another named brand from a pharmacy, and I could pretty much expect it's going to be the same thing. And if it's cheaper, I might jump at that. That's great. But when you get to the biologics, it's different. With infliximab, we now have in Canada Remicade and Inflectra. Remsima also was approved by Health Canada. But both of these, or all 3 of these, are named infliximab. That can matter. It can matter if I had a reaction to one of these medicines. And I reported it to Health Canada and said it was infliximab. But which infliximab was it? Health Canada hasn't really decided on how they're going to name these products to differentiate them, though they clearly recognize that there's a need for it. That's important. Why have they hesitated? I think quite rightfully they waited for the World Health Organization to come up with guidelines. If we came up with Canadian guidelines, that wouldn't play very well when we were reporting our adverse reactions or any other important information to the World Health Organization. If every country called it something different, it would be a mess, maybe even a bigger mess than it is now. So we're waiting for the WHO to come up with guidelines. And draft guidelines were indeed enacted in July of 2014. But the final word isn't in yet, but I suspect we're not far from that. When we start finding out what the unique names are, we'll be able to do things that we can't do right now. We'll be able to say, you were on this one, we can't change you to that one because there's a concern changing from one infliximab to another. Or we can say, you're on this infliximab. If something didn't work, or if you had a side effect and we have to report it or consider what to do next, we would know which infliximab it was. In fact, we would also know in which of the few factories in the world it was made. If there was something in the process, and remembering how important that process is, if there was something in the process that was unique to an infliximab made in a country in Asia, or a country in Africa, or a country in Europe or North America, and we knew exactly where it was made, we could go back if those reports were coming in and say, was there anything that changed that mattered, that caused this failure or this side effect? So this whole idea of naming is very important, and important to patients and their families and their caregivers and the people who deliver it. If you're getting a medicine like infliximab and it's given intravenously, you want to make sure that the people who are supplying the pharmacy, the person who's hanging it up, tells you, this is Remicade, this is Inflectra. You need to know. It's very important, and it's up to you to make sure that that's happening because you know how important it is.